I want to thank all 140 of you who've joined so far. We're expecting maybe double or triple that. And I'd like to turn it over to Dr. David Miller from the Department of Health, and he's in charge of disaster preparedness for New York City Department of Health, and he just has a few opening remarks. Take it away, David.
Thank you so much, Dr. Frogel. Good afternoon.
Correct.
Thank you to everyone for joining us for this really important briefing on the rise of respiratory illness in pediatric populations in New York City, the impact of care facilities, staffing, and supply chain, and an opportunity for gaining a good situational awareness of pediatric surge. This will involve what actions you can take at your practice in your facility or with your health systems now. My name is David Miller, and I serve as the Executive Director of Healthcare System Readiness in the Office of Emergency Preparedness and Response in New York City's Department of Health and Mental Hygiene. In this capacity, I oversee the New York City Healthcare Coalition that focuses on collaboration for emergency management capacity building across New York City's healthcare delivery system, as well as with our community partners that support that delivery system in New York City. We leverage the National Healthcare Preparedness Program, the only federal grants funding for healthcare emergency management. Today, I'm joined by a variety of subject matter experts in pediatric disaster management. Doctors Michael Frogel, Ellen Lee, Matthew Harris, and Bruce Greenwald will brief you in this very important step in public health warning and notification for this emerging incident of surge impact. Please share this recording with those who were not able to make it today and those across your network so we can get the information out in a timely fashion. This is a very important part of the capacity building in public health emergency. I'd like to turn it over to the Senior Director of Healthcare's Coalition Operations, Ari Rubenstein.
Thank you, David, and thank you everyone for attending. It's amazing to see over 160 people currently on this call that we just put together over the last 2 days. I think this is a really great testament to the strength of our coalitions here in New York City, that we were able to put together this meeting with so many of our partners in the wake of what seems to be a very significant rise in patients with acute respiratory illness. The Healthcare Coalition has several subject matter experts, several groups that we work together with. As the Senior Director of Operations, I oversee our relationship with PDC, and it's really such a fantastic group that not only serves as subject matter experts, but helps us to develop plans for preparedness and exercises here in New York City. We're really grateful for this relationship and for the fantastic work that Dr. Frogel and his team does. I will pass it over to Dr. Frogel, and thank you everyone for attending.
Thank you, David and Ari, and the kids really appreciate your support. And we're talking about a very important topic today. I'm going to just be discussing very briefly what the Pediatric Disaster Coalition is about in New York City, and then we will move on to get an update from Dr. Lee from the Department of Health about the current outbreak of acute respiratory illness, followed by Dr. Matt Harris and Dr. Bruce Greenwald, who are from two of the biggest systems in the city, who will be discussing the impact of the current outbreak and strategies they've used to mitigate against it. Then we'll have a Q&A through the chat and a discussion about what we can do for this outbreak and for future things that may happen so that we're best ready and prepared for surge. Okay, so John, next slide. Okay, so we just a very brief discussion about what the New York City Pediatric Disaster Coalition is. So we're funded by the federal government through the New York City Department of Health, and we have membership which is very broad from all the hospitals that treat children in New York City, even outpatient departments, urgent care centers, long-term care facilities, medical reserve corps, agencies such as Department of Health, the fire department, emergency management, et cetera, et cetera. So we try to be inclusive of all the stakeholders that care for children. We're a member of the New York City Governing Board and part of the executive committee and kudos to New York that they've recognized the needs of the 25% of the population who are children, who are extremely vulnerable and do have special needs during disasters. We've developed a citywide planning and response network that we've put together, and we hope to make that active as a CONOPS as soon as possible. It goes from primary transport to secondary transport to surge and evacuation. We have a pediatric intensive response team run by Dr. Bruce Greenwald. They're on 24/7 to provide SME and prioritization for secondary transport. They're unique in the United States, and many people are now copying that. We also helped develop the pediatric annex for the New York City disaster plan. Next slide. And we have guidelines that we've developed, and we're happy to share about all the different pediatric units, intensive care, even obstetrics and newborn, et cetera. We've done a lot of exercises. We'll talk about that a little bit later, because I think they're very important in getting things to be operationalized. And we presented at national, local, and international meetings on a very frequent basis to let them know what we're doing. And we've actually been involved in the response to many different difficult events, including COVID, and now this outbreak. Next slide. Okay, and this is just a depiction of what we wanted to do. You know, our goal is to prepare New York City for a catastrophic pediatric event, beginning at the start. This is more related to an acute incident, but it certainly pertains to pandemics, et cetera. And we start at the beginning, and then we've tiered our hospitals for primary transport, secondary transport, surge and evacuation, and we have a comprehensive pediatric disaster plan. We'll discuss a little bit more later. So with that as an introduction, I just want to tell you why we've decided to go ahead and do this on pretty short notice. There is a national crisis that exists today due to respiratory illness in the United States. There are some states that are having major problems and are even thinking about sending kids home on oxygen, which is somewhat unheard of. There are emergency rooms that are opening up tents. It sounds like COVID, and it's not. The incidence of COVID is really not that great at the present moment, and we're seeing outbreaks of RSV, other respiratory viruses. We're too soon to start with influenza. So we thought it would be important to get the epidemiology of what's going on in New York City, to have two of our systems discuss how they've been impacted and how they've handled it, and then have an open discussion about what we can do during these types of surges. So at this point, I'd like to turn it over to Dr. Lee from the New York City Department of Health to discuss the current effects of respiratory viruses in New York City.
Great, thank you so much for that introduction. And I'm wondering if, oh, excellent, thank you so much. Hi, I'm Ellen Lee from the New York City Health Department in the Bureau of Communicable Disease. And I'll speak with you just for a few moments, just to give you the context and epidemiology of what we're seeing in terms of respiratory infections here in the city, with a focus on pediatric populations. May I have the next slide, please? So hopefully you're able to see these, this graphic. This slide is from our syndromic surveillance system, and this system draws on data reported from New York City emergency departments. It means that these data are non-specific and they're not based on laboratory diagnostic testing. What we can see here illustrated is the total number of ED visits for respiratory illness and asthma in those under 18 years of age. And this includes ED visits with specifically either chief complaints or diagnostic codes for shortness of breath, cough, URI, pneumonia, chest cold, asthma, and wheezing. So all of those are combined into this what we call a syndrome of respiratory/asthma, and that's what you see here indicated on this graph. So this graph has the total number of ED visits for the 2 years before the pandemic and for the current year. So you can see that 2018 is the blue line. Sorry, I don't have control of the screen, but if you can just follow the colors, 2018 is the blue line, 2019 is in orange, and then 2022 is in purple. So what you can see is that, and I think you already know this, but this fall has seen a higher volume of ED visits for this respiratory asthma syndrome when compared to 2 years pre-pandemic. May I have the next slide, please? So I know this is a sort of a busy slide, but if I can break it down, this is the number and proportion of all ED visits, the total number of visits, as well as by age. So at the bottom, if you can sort of focus on that gray squiggly line at the bottom, that's the total count of ED visits in the gray line. And this is the raw count of ED visits. So you can see that there is a uptick in sort of late December, early January, and then you can see the uptick now in the fall of 2022. If you go up above that gray line, you can see this is now the proportion of all of our ED visits for this syndrome represented by each age category. So I'll call your attention to the top line, which is the black line, and that's for patients ages 0 to 4 years, and the green line, which is for patients age 5 to 17 years. So again, this part of the graph is showing the proportion of all visits for this respiratory syndrome that are represented by different age groups. So as you can see, the youngest kids do represent the highest proportion of all these visits, over 40%. And then the second highest proportion is represented by the age 5 to 17-year-olds. And so between the two, those under 18 represent what looks to be over 60% of all ED visits citywide for a respiratory illness. May we have the next slide, please? So this again, I'm sorry, it's a busy slide, but it's a bit different in that this is specific to RSV emergency department visits and hospitalizations among pediatric patients. And this is now using just the last year as the time frame. It's different from the previous slides because for this graph, it includes ED visits for people who actually had a positive RSV test result within 5 days, either before or after their ED visit. And that is represented in that sort of orange-yellow line, as you can see at the top. And then RSV hospitalizations are similarly a positive RSV test result within 5 days of hospitalization, either before or after that hospitalization. And we use the discharge disposition code that is sent by EDs. So again, I think this will be no surprise, but RSV in particular has seen a very rapid incline. And these data go up through the beginning of this week. And so I think we don't yet really see a sense of a change in the trend yet. You'll see that there's sort of a lot of jagged edges to this graph, but that can be due to what we know to be reporting differences and healthcare seeking differences based on the day of the week. And it also can take a little bit of time for data to fill in for the most recent days or week. So again, the orange indicating just a tremendous increase in RSV ED visits, and then the blue indicating similarly an increase in RSV hospitalizations. May I have the next slides, please? So the next few slides will be specific to influenza. I think Dr. Fergal already mentioned that, it does seem like perhaps other viruses, not flu and COVID, are responsible for what you're seeing, but I did just want to show you what we have in terms of influenza data. So all clinical laboratories that perform testing on New York City residents report their positive influenza test results electronically to the health department. And then in addition, we actively solicit additional data on influenza test results from a large sample of New York City laboratory facilities that are licensed to perform influenza testing. So these laboratories are contacted weekly to obtain data on the number of influenza tests, to obtain data on their number of influenza tests. During the week ending in October 22nd, which was the last week for which we have data, approximately 2% of all specimens submitted for influenza testing were positive for influenza. So that's now the red line that you see there. You can see that based on comparison with other years, this year is seeing actually an early increase. So 2% does not seem to be like a lot, but when you look to see the last couple of years represented in green, blue, yellow, and light blue, this increase that we're seeing now is a bit early. Now, this is not restricted to pediatric ages, it's for all ages. May I have the next slide, please? New York City also participates in what's called the Outpatient Influenza-like Illness Surveillance Network, or ILI-NET, which is coordinated nationally by CDC. This system monitors the proportion of patients presenting with influenza-like activity each week at emergency departments, at urgent care centers, and primary care clinics. So this ILI-NET monitors visits for influenza-like activity, not laboratory confirmed influenza. And as a result, it might be including patient visits due to other respiratory pathogens that have similar symptoms. During the week ending on October 22nd, approximately 5% of all visits in these different outpatient facilities were due to influenza-like illness. Again, these data were not restricted to pediatric ages, but as we saw in the previous slide, what we are seeing with ILI-NET also represents an early increase relative to the last 2 years. May I have the next slide, please? So DOH receives data from selected New York City laboratories that test for an expanded panel of respiratory viruses circulating in New York City. So this is a snapshot. So this is not over time, but it's a snapshot for the week ending in October 22nd. And you can see on the x-axis the different etiologies that are tested. And as you can see here, a little over 20% of those positive results were due to rhinovirus enterovirus. I have to give the disclaimer that this is a convenience sample. It's not necessarily representative of the city, and we don't have data about the age for these positive results. So I think I present that just to indicate that, at least in mid-October, we did see more positivity from rhinovirus enterovirus, but I don't think but given this sort of the context for RSV as well, I don't think that we can say that this picture tells you the overall picture for all circulating respiratory viruses in the city. I should also mention here that these last few slides related to influenza are all available in a weekly influenza report that's prepared by the health department during the flu season, and it's available on our website. May I have the next slide, please, which is actually the last slide. And so last, I'll leave you with a plug about the available prevention measures. There's the monoclonal antibody Synagist, which has been approved since 1998 and is recommended for infants with gestational age less than 29 weeks and certain other infants and children with high-risk conditions. Influenza as well as COVID. For influenza and COVID, as always, we strongly recommend getting vaccinated, including getting vaccinated with the new bivalent COVID-19 booster for those who are eligible. So that is the end of my presentation. Happy to take questions later or in any Q&A. Thanks so much.
All right, Mike, let me just hop in. All right.
So thank you very much. So thank you, Dr. Lee. That was eye-opening because it looks like we're at the beginning of something, and flu hasn't really even started. And RSV obviously is increasing dramatically, and as you'll hear from Matt in a minute, and Bruce Greenwald, our EDs and hospitals are starting to become overwhelmed, even at this point in the early beginnings of the fall and winter. So I'd like to turn over now to Matt Harris, who is part of our Pediatric Disaster Coalition Advisory Board and is always there for us to help out when needed. And He's from Northwell Health. He's a peds emergency medicine trained attending in the ED there, but also in charge of pediatric disaster preparedness. Take it away, Matt. Thank you.
Thanks so much, Mike. I'm going to apologize. Appropriately enough, I'm at the tail end of RSV, so this will be a telltale for all of us on the provider side. So thank you very much. I'm the medical director for crisis management here at Northwell Health and pediatric emergency medicine attending. And I will speak about our experience here, some of the mechanisms we're using to help mitigate some of the stress on our children's hospital. I imagine that many of the graphs I'm going to show you now will be very similar to Dr. Lee's, with that very notable uptick and upslope in our viral illness pathogen presentation, and hopefully this will be somewhat useful for other health systems as well. John, you can go to the next slide. So like many systems, we collect routinely patients presenting with a viral syndrome that's either a positive respiratory panel, or there is a slew of ICD-10 codes, URI, et cetera. And we collect this information. You can see that in the last several weeks, it's just been a gradual uptick. As of last update, which was yesterday, 33% of all ED visits are for children presenting with a upper respiratory tract infection. You can see that's well above our normative values for this time of year. Sean, you can go to the next slide. I'm going to focus for a moment on RSV, as did Dr. Lee. You know, what's really notable here is that RVPs here, and this data is as of 72 hours ago, represented just under 40% of all positive viral panels in our children's hospital. When you expand that out to this morning, it's up to 51%. We had such a dramatic increase in volume, which we'll speak about in the last 3 to 4 days, that the volume was sufficient enough to actually change our statistics. RSV has represented the overall burden in positive RVPs in our emergency department, both here in the Children's Hospital and throughout the 23 hospitals of Northwell's emergency departments. Go to the next slide. So I'm going to speak to the experience here in the Children's Hospital. Our emergency department volume in October, and this is in comparison to 2019, our last sort of quote unquote normal year, is up 40%. Which translates in our numbers to about 250 to 300 kids per day, which is well above our normal average. At a typical time in October, I'd say we average around 190 to 210 visits per day. Last night we saw, in the last 24 hours, we saw 324 kids. So the strain on the emergency department here alone, and not even accounting for the other emergency departments within the health system, has been very real. We've seen an uptick in our admissions by 48% compared to this time last year, but most notably, these are patients under the age of 2, many of whom are requiring heated high flow nasal cannula almost exclusively for bronchiolitis, though with the uptick in entero, adeno here as well, we are seeing more and more kids who are getting admitted for dehydration, poor PO intake. So these general pediatric patients have really been the lion's share of our admissions. Our PICU admissions, which I'll speak about shortly, have also gone up, and the acuity certainly seems to be slowly climbing, but not nearly as fast as the general pediatrics patients. Also growing is the number of patients who were treated and released, up 26% from the same time in 2019. And this is a real opportunity for us in the emergency department to identify mechanisms to see these kids quickly, not have them clog up the emergency department as we have to deal with boarding patients like many other institutions here. We have not had to transfer outside of the system, but I will speak to some mechanisms we're using here in the health system. An interesting note, our statistician emailed me this morning and said that if you look in the past 5 years, the ED registration with the 5 highest volume days have all been in the last 2 weeks, just to paint a picture of what we're seeing. So 283 actually to 324 is what I should say. So just incredible volumes, really reflecting the impact of this respiratory surge. Next slide, please. Just a snapshot from 11 o'clock last night in finalizing this lecture. We had 111 kids in our emergency department, 53 in the waiting room. We had already seen 270 who were treated and released, and we had 12 boarding. So this becomes a real impact on hospital operations as well. Next slide. So there's a couple of things I'll bring to note here. And again, I think these slides are being made available so people can feel free to terse through the data. But if we look on the right side of your screen, this are the number of patients per month who've had to experience a hold after admission. This includes both PICU and hospital admission in the emergency department for greater than 12 hours. And I think during the normal operations of the year, we'd like to get kids up within about 2 hours. So greater than 12 hours being really our red flag for us. And you can see that compared to this time in 2019, we're up, almost 10 times compared, 71 holds for greater than 12 hours in the emergency department. And we've had to really flex up our staff in order to ensure that they continue to receive the quality of care that we, provide here at the Children's Hospital. But the sheer number of holds, even just in the last several months, I think is dramatically higher compared to where we were in 2019. And that being said, our overall ED volume is going to probably close to 70,000 this year, whereas in previous years we were in the high 50s, low 60s. So the last 2 to 3 years have just seen an overall increase in volume. The last several weeks have seen increases in the door-to-doc time, door-to-dispo time. So operationally, this has just become a tremendous challenge. Next slide. This is the October admits. On the top of each line is the number of admits per day for the month of October. The light blue and gray reflect floor admits, whether it's a surgical service or a non-surgical service, and the dark blue reflect our PICU admits. You can see that the percentage of kids requiring ICU care has remained somewhat stagnant. Our PICU census has been somewhere between 95 and 104% for the past, I'd say, 2 to 3 weeks. We'll speak about that in upcoming slides. Next slide. So who's driving the bulk of these admissions? So the green line on the top represents the number of admissions per month. This reflects back all the way to 2018 on the left, to date on all the way to the right. And what you can see is that, in the month of October, we admitted, well over 900 children to the Children's Hospital. And I'll draw your attention to the upslope in the 2 lines on the bottom, which reflect kids 2 to 5 and 0 to 2. So in grossly speaking, kids under the age of 5 have really driven the spike of admissions in the month of October, late September, early October. Next slide. So let's talk about some of the things we're doing here that I hope can be helpful in other locations as well. Because of the increase in number of low acuity patients presenting, those are predominantly the ones who end up being treated and released. We've really tried to increase our urgent care hours of operations, what we call our emergency department annex, which is staffed by our pediatric emergency medicine physicians and ACPs, to close to 24 hours a day. Some days we've had it 24 hours a day. I'd say on average, it's been about 20 hours a day. And that's really meant to facilitate the early evaluation and management of those level 4 and 5, ESI level 4 and 5 patients. So they're not having a length of stay in the waiting room that's too terrible. And most importantly, they're getting seen quickly and not clogging up, very, very valuable emergency department space. And again, that target population is ESI 4 and 5. And in the last several days, our urgent care clinic, for lack of a better way to call it, our ED annex, has seen about 80 to 100 kids per day. So this has really helped operationally debulk the emergency department, leaving the higher acuity patients inside. This has required a very significant influx of nursing, which I think has been valuable to us, and I know has been a hardship for many health systems, including our own. We are doing lots of pediatric competencies. We are bringing in additional PEM providers, and pediatricians from the community have helped augment the hospital to allow some of our other fellows and attendings to remain in the emergency department. Next slide. I just want to draw your attention to the fact that, like many, our hospital capacity in the last several weeks has been well over 100%. On Monday night or Tuesday night, which was our really busy, the 323 night, we were at 125% capacity. And this just really, I think this becomes a point where we are well beyond using alternative care spaces within the hospital and really stretching to find a safe and appropriate place to do so, which we've managed to do. And I think it has to do a lot with the planning that the health system has put together, both here in the Children's Hospital and within the health system. We'll speak about that in a moment. Next slide. When you look at that maximum census, which we saw as 125 on the previous slide, and just to draw attention, the black line is 2022, the green line is 2019. This graph demonstrates the maximum census at any point in the year, going back to 2019. And on average, our census in the last several months has been 44% above our baseline high. So again, just driving home the point that we are seeing just incredibly large numbers. I'm sure Bruce and team will reflect that as well. Next slide. So the hospital service has really been very innovative here. So in addition to bringing in, having more resident coverage, more fellow coverage, additional hospitalists, there's a balance between burning out your staff and having appropriate coverage, I think is a game that all of us are playing. They are using every available alternative care space in the Children's Hospital. But one of the things we started doing in the last several days is we're level loading or load balancing out general pediatrics patients to other pediatric floors that are staffed by Cohen Children's physicians and nurses at other Northwell hospitals. We have several other floors at 4 other hospitals in the health system right now. We're anticipating opening up some more. And that's just because we need additional space to provide general pediatrics care. So we really try to identify these patients as those who will not require intensive care based on their Pew score, other markers. Those are unlikely to require pediatric surgery. And we're certainly leveraging our telehealth consultation process in order to facilitate, if there's a nephrology consult or something relatively low hanging that we can do from afar. But this is a real testament to the health system's commitment to finding additional spaces and staffing them appropriately. I think most of the children's hospitals on this call, we're doing heated high flow nasal cannula on the floor for broncholytics. I will tip my hat to the hospitalists. They are really have expanded the types of patients that we can admit on high flow to the floor. We've admitted several patients with pneumonia, older children than they're used to on high flow, kids who would otherwise go to the ICU, which is well beyond its capacity at this point. So I think broadening their scope and their comfort level has been a really significant push from the hospitalist. Next slide, please. This is our critical care census for the month of October. We have a 30-bed a 30-bed ICU. This does not include, gosh, I think it's 12 beds in the step down. So you'll notice that most days here we're well over 30, and that is required the intensive care team. John, you can go to the next slide. That's required the intensive care team to utilize alternative critical care spaces, which are notably much more difficult to come by. That will include emergency department space as a backup, the step down unit, the PACU. We've not yet had to use an operating room, but it's on the list of things that we can flex into the way we did during COVID for adult patients. A challenge is getting staff, much like the emergency department. There are not a heck of a lot of people that can back up into the critical care world. So we're working with our adult colleagues to understand what types of patients can be in a medical ICU, what types of medical ICU staff can augment our critical care staff, mostly in the realm of nurses with pediatric competency as sort of flex nurses to back up our PICU nurses. Hasn't really been something much in the MD space. Next slide. So I believe this is the last slide. I think that I would be remiss not to mention the fact that this has been a team effort since the beginning. So we have activated the emergency management team from our corporate partners, as well as the Children's Hospital. This has been invaluable in standing up new units de novo, whether it's within the LIJ campus or outside of the 4 walls of our global campus. And just in terms of getting equipment, operations, pharmacy, and so forth, really is a robust thing. One of the things we've really done in the last several days is we've communicated out to our emergency medicine colleagues a lot of our clinical care guidelines, because I think one way to debulk the Children's Hospital is to prevent admissions from coming over. So if there is a kid who's clinically well enough to come home, we introduce things like the bronchiolitis respiratory severity score. We empower our emergency medicine service colleagues to really identify kids who are appropriate for discharge and minimize the number of kids who have to come over, whether they require admission or not. And finally, we mentioned the load balancing effort. This has required a huge effort from our Institute for Nursing and from our clinical care teams to ensure that not just the physicians and the hospitalists at those locations, but that the nursing team and the respiratory therapists and other ancillary services have the adequate pediatric competencies. So really, this has required and benefited from the system's dedication and response to this surge. With that, I will thank you guys for the opportunity to speak, and I'll turn it back to Dr. Frebel.
Thank you very much, Matt. That was an excellent review, and you guys have really stepped up the plate. And we're hoping this is the peak, but with influenza around the corner and some new COVID variants out there, this is all about surging and getting ready to do much more. And I think the strategies that you employed were really excellent. And we're going to hear now from Dr. Bruce Greenwald, who's been an amazing participant in our Pediatric Disaster Coalition activities. He's in charge of our Pediatric Intensive Response Team, and he's chief of the Pediatric Intensive Care Unit at Cornell and part of the Presbyterian system. So without further ado, Bruce, please take it away. Thank you.
Okay, thank you. Next slide, please. So a lot of this is going to be a redundant. Dr. Lee and Dr. Harris covered much of this, so I'll try to go through this quickly. So this shows respiratory viral trends at our hospital, which includes Weill Cornell Medical Center in New York Presbyterian System and Lower Manhattan Hospital. And you can see that we're showing first the SARS-CoV-2 spike that happened in January, late fall and into January of 2022. And then the rhinoenterov spike that we just experienced, and that's starting to go down. That was in September, and then the RSV spike that is occurring now. Next slide, please. Okay, so this is shortening the window a little bit. Now we're looking at June of this year through October, and we could see that in June there was a bit of a SARS-CoV-2 spike, then rhinoenterov and RSV. On the left side, you see the number of positive tests, and on the right side, you see the positivity rate, with rhinoenterov being the leader in terms of percentage of positive tests in October, and RSV following right behind that. Next slide. This is looking at the RSV positive tests, which we've already seen that, and showing that the RSV season is no longer just spring and winter, but it's starting in July, and on the right side of the left-hand panel, you can see that RSV started to increase in July of this year, and this is the same, the RSV positive tests at our hospital on the right side of the screen. So it's just, this is redundant, so let's go on. Next slide. I think we saw this too. On the left-hand side, this is a slide that's already been shown to you by Dr. Lee. And this on the right-hand side of the slide are the influenza positive tests that we're seeing in our hospital. So we're starting to see the same spike that New York City is seeing. Next slide. And this is the rhinoenterov spike, which peaked in September. Next slide. This shows you the number of patients seen in RED. We're comparing 2019 to 2022. So just as Dr. Harris showed, we're seeing an increase in volume over 2019. 2019 is shown in green, and 2022 is shown in red. And you can see as we move towards weeks 41, 42, 43, and 44, where our volumes are going up, just as has been seen in every other emergency department in New York City. Next slide. I wanted to say a word about the Morgan Stanley Children's Hospital, which is has a bigger emergency department than we do at Weill Cornell. They've been on critical diversion part of every day for the past 3 to 4 weeks. Their inpatient services have been operating at and above capacity for the last 3 to 4 weeks. On average, they have between 8 and 16 admitted patients on hold in the ED at any given time, and that doesn't include the behavioral health patients, which would be a separate conversation. And the ED length of stay has been up to 3 days waiting for beds. Just as Dr. Harris talked about, we've done some level loading by transferring patients from Morgan Stanley to our hospital. And I'll show you our hospital experience now. Next slide. So this just gives you a sense of the number of beds that we've been operating with pre-COVID. Our total number of active beds were 61, with 26 general pediatric beds, 12 intermediate care, and 23 intensive care. With COVID, we created all single patient rooms, and so we dropped down to 52 active beds. And now with the surge, we have gone up to, we're currently operating with 64 beds, but we can go to 70, and we haven't needed to use that many yet. Next slide. So this shows our total number of inpatients. And as you can see, in September, we peaked out at about 52, and now we're rising up to 56, and we can go, without having to create new space, we can go up to about 60. There are plans to open up space in, we recently, in the last year, moved our NICU from one location to a new building. The old NICU space is designated for construction to create new pediatric ICU beds, but that construction hasn't started yet. So we are now in the process of preparing to use those beds prior to construction as inpatient and/or emergency department beds, depending upon the need. Next slide. Do you want me to do this now, Mike, or was there something in between?
No, you could go ahead and do it. Bruce is just going to give a brief overview of what bronchiolitis, usually caused by RSV, is all about, so people just have an understanding of the needs for the patients.
So
Go ahead.
yes, well, often caused by RSV, but as you know, rhinoentero and adenovirus and human metapneumovirus can all cause a similar syndrome. So very quickly, this is going to be quite redundant for those of us who practice pediatrics, pediatric emergency medicine and pediatric intensive care. But for those who don't see these kinds of patients, the pathophysiology is a respiratory viral infection. It causes nasal congestion, airway congestion, mucus plugging, in addition to airway inflammation. This creates tachypnea, hypoxemia, hypercarbia, and in infants, especially with RSV, we see infants becoming apneic. It also can initiate a reactive airway disease and bronchospasm. This is seen more often in older patients who have a genetic predisposition to reactive airway disease or asthma. Sometimes the first presentation of asthma happens when children have a respiratory viral illness such as RSV. It's particularly pertinent to former premature infants or those with chronic lung disease, or other patients with chronic lung disease who frequently wheeze when they get these respiratory viral illnesses, and certainly patients with asthma, their asthma can be exacerbated by RSV and other respiratory viral illnesses. Next slide, please. So the management is supportive. There are no antibiotics for bronchiolitis. So the supportive care includes suctioning, nasal saline, normal saline nose drops, supplemental oxygen when necessary, fever control, and considering some use hypertonic saline nebulizers to help break up the mucus. And some patients are responsive to that. Respiratory support can run the whole gamut of the kind of respiratory support that we give to patients with respiratory illnesses. We often start with high flow nasal cannula, well, standard nasal cannula, then progress to high flow nasal cannula. Heliox can reduce airway resistance and reduce work of breathing, and some patients experience relief when given Heliox. Those patients that need advanced level of respiratory support, we can start with non-invasive positive pressure ventilation, and that would either be CPAP or progress on to BiPAP. And then those patients who develop respiratory failure need to be intubated and put on mechanical ventilation. And in extreme cases, extracorporeal life support in the form of ECMO. We currently have one patient with RSV on ECMO in our ICU today. Specific treatment for those patients that do have reactive airway disease and develop bronchospasm would be standard bronchodilators, which would include albuterol or terbutaline for those patients who are sicker and not responsive to albuterol. Ipratropium can be helpful, especially in those that have lots of secretions. Corticosteroids are used in the same way that they're used for children with status asthmaticus, usually a 5-day course of corticosteroids, and chest physiotherapy can sometimes be beneficial, but not in every case. Next slide, please. Mike asked me to say a couple of words about supply chain. If the surge continues, we will need additional places to monitor patients. So we need cardiopulmonary monitors in places that are not usually used for the care of sick and critically ill patients. That requires the monitors and cables. Pulse oximeters are needed and pulse oximetry probes. Thus far, we have not been running out of those, fortunately. The respiratory support requires high flow devices and the actual cannulas, face masks for those children that can't tolerate nasal cannulas or those who are on face mask BiPAP, suction catheters, suction devices, CPAP and BiPAP machines, as well as ventilators and the tubing associated with these devices. And if we are going to be using Heliox, we have to recognize that there is a limited supply of helium on the planet. Medications. Currently, the albuterol that we use for continuous nebulization, which is a concentration of 5 milligrams per ml, is in short supply in our formulary. So we will have to go to other concentrations. Terbutaline, there have been shortages of terbutaline in recent years. We haven't experienced ipratropium shortages, but that's another potential. And corticosteroids, fortunately, you can use prednisone, methylprednisolone, and dexamethasone. So if there's a shortage of one, they are interchangeable in these patients. And I believe that's all I have.
Great, thank you so much. That was really great. So we want to move on now to, after hearing about the impact so far, and remember, we're just at the tip of the iceberg with influenza, and there are variants of COVID lurking out there. They're up to 11% in the United States, which may be more infectious. And we hope this doesn't get worse. You want to discuss what we can do. You heard a lot of the different strategies from alternate care sites, getting more sites to take care of pediatric patients that would normally be in the intensive care unit, and the other strategies that you've heard so far. So if you can put in the chat, and we will try to catalog what's put in there and answer questions, but we will not be able to answer everything, obviously. But we also want to get a sense from you of what you guys are seeing and what problems you're having. I also urge you to contact the Pediatric Disaster Coalition. We'll give you our contact information, and also the OHMH as necessary to bring to light any supply shortages or other problems that you're having. I know we're all having staffing shortages and limited supplies, but we need to maximize our response so that we can get the best outcomes. I just want to discuss what Bruce said. There is a national shortage of albuterol in certain concentrations. The federal government is working with the manufacturer on that. I just had a whole bunch of slides I'm not going to go through, but you have a very large number of slides about how to surge and the different strategies to surge, and not to forget about pediatric disaster mental health, not to forget about healthcare disparities. There are certain populations of patients who really don't have good access to care. We need to be very concerned about them, and other special populations with handicaps and other problems that we need to really consider. We really want to know if you're considering going to altered standards of care or crisis standards of care, which some people around the country are considering. And that's really kind of catastrophic. That means that we have needs and not appropriate resources to manage it. That's why we have to consider load leveling and all the other possible things that could help us. We are working also with the national ASPR and CDC, and all the other players to try to get a strategy which will allow us to do this on a regional basis. And in New York City, we'd really like to move that up so that no individual hospital is suffering while others are, flush with resources. So that's really what load leveling is about. I see a question in the chat about increasing the guidelines for Synergist. There's nothing on that as yet. Synergist is a very good preventive. It's given by monthly injection, but it's still only indicated in limited number of patients. There is not a huge supply of Synergist. There are spotty shortages already in the country. It's problematic, and it's even in select patients. The bottom line is that Matt told me earlier that there are some kids, normal, healthy young infants who are on ECMO and having really serious problems. I see that the chat is working, and Matt and others are answering questions, which is just great.
Can I answer Mohammed's question? Would that be
Yes,
all
of course. Go
right?
ahead.
Mohammed asked a series of good questions. So critically ill patients in RED are being managed by pediatric emergency medicine physicians with ICU consults if needed, and the emergency medicine nurses. High flow nasal cannula, we have started to do that on our floor, and we did make a cutoff of those patients that require 35% FiO2 or less can remain on the inpatient services, and if they are progressing to require more than 35% oxygen, then they are moved as soon as possible to the ICU. How do you handle when kids on high flow worsen? Yeah, then they move when they worsen from high flow and need non-invasive, then they get moved to the ICU. And how do you handle transfer requests if no physical ICU beds? We are squeezing patients into the ICU from within our system. Unfortunately, when we're full, we're not able to take patients from outside of our system because we have patients waiting in our EDs for ICU beds within our system. So that becomes a big problem if the surge progresses.
Thank you very much, Bruce. We go on to the next slide, please, John. Okay, so these are just some considerations for surge planning and response. You've heard a lot of things that are already being done. It would be great to have statistical data on a daily basis, and we're pushing very hard to be able to collect all the salient information about PICU occupancy, number of kids on ventilators, the etiologies, and try to get a handle in a citywide basis of what's going on. And hopefully we're close to be able to get that data from emergency departments and hospitals. I think it's important to, there is a pediatric intensive care group that works together, as well as the ED, is to discuss the different things amongst them and put their brains together to come out with best ideas. Utilization of adult resources should be considered by everyone, just as we did, and Cornell did a great job in having a pediatric unit convert into an adult unit. I think with appropriate supervision and contact, certainly the older kids and others could be cared for with adults, as long as they're not in kind of catastrophic situations. I think it's kind of reverse of COVID. There may be opportunities for telemedicine, especially for outpatients. Alternate care sites would be very useful if you can staff them, and opening alternate sites in areas that are not being utilized, as Bruce mentioned, the NICU being used for PICU beds, and using pediatric floors to care for somewhat sicker kids, maybe with the oversight of some PICU help, would be very helpful. Next slide.
So unfortunately, Mike, it's not a two-way street with our adult colleagues, because most of these kids are under 2 who are
Right.
sick, and
Of course.
our adult colleagues are quite afraid of them.
Yes,
Mike, I'll just kick in there that I think that we have been able to engage some of our adult emergency medicine docs to work in our sort of rapid assessment urgent care setting, which still has pediatric nurses and ACP, someone up there who can be an added set of eyes. But I think to help debulk some of those 4s and 5s, there are some pretty talented adult or general emergency medicine physicians out there who are very, very comfortable with kids. I think just finding the right one, to Bruce's point, is important.
Okay, thank you. I want to try to wrap up relatively quickly, but I think it's very important that we ensure that the practitioners, the urgent care centers, et cetera, maximally utilized and perhaps have open hours more often to prevent kids from coming to the ED who really don't need to be there. I think public messaging is very important to allow parents to understand when they should seek medical care, when it's kind of normal stuff. And I think DOHMH and others are doing a good job of that, but we certainly can enhance that. I think activation of emergency operations centers based on HICS planning is very important. And if this gets really bad, we should consider opening a medical operations center for the city. I think people on this call, have now been alerted to what's going on. We are concerned that this will get worse before it gets better. That's why we wanted to hold this. And we really urge you to be in touch with us and DOHMH about any issues that are going on so that we can offer help and we can develop a citywide response that includes all of the different issues regarding supply chain and bed utilization, et cetera, and try to make a level playing field against this very difficult times. Next slide. Okay, we can skip this. This is about regional beyond state planning. Next slide. But please go over these slides. They're there for your use. So we want to thank you on behalf of the kids. We have a whole bunch of resources that we will be sending out to you with the recording as well as the slideshow. And you see where you can reach us. And all these resources, we have pages and pages of resources about influenza, about RSV, about all different kinds of things that are available out there. And please feel free to contact us about that. We want to go from silo response for surges to a cohesive team kind of response. And the best way to do that is to share information and share strategies, which I hope we've done today with this limited amount of time. Here are special thanks to the people who participated today. We want to special thanks to Dr. Lee, who participated from the DOHMH, and all the others here. And you can feel free to contact us for further information. Next slide. I think that's it. Okay, so we have gone through our hour. I hope this has been helpful, and we would appreciate greatly for you to work together and in a cohesive manner. That gives us our best shot at overcoming these surges. And unfortunately, it looks like they'll continue, but a team is the best way to go. I want to thank you very much for your participation. More to follow as time goes on. Thank you very much. Be well.